Delighted to welcome Professor Ian Pearce, who's here this afternoon to talk to us. He's a consultant urological surgeon at Manchester Royal Infirmary, and he's here to talk to us about treating benign prostatic hyperplasia, which is easy enough for you to say, but over to you. Thank you very much.
Thank you. Thank you very much. Can you all hear me okay? Okay. That was a bit like a Heidi High moment, wasn't it? Is anybody old enough to remember Heidi High? God, did anyone say no? Oh, yes. Good. It's just something I heard my parents talk about once, but still. Well, first of all, thank you for inviting me. It's really great to be here. It's nice to get out of Manchester, which is only, of course, a couple of hours up the road, or 90 minutes, something like that. So it's a real pleasure to be here, so thank you very much. I hope you've all had a great morning. I'm always conscious that they put me on again after lunch, which basically means when I look across, probably half the people will start sleeping, which is okay. When I was very much younger than I am now, I might have been tempted to walk up and down to make sure everyone was awake, but I'm slightly conscious that I could easily break my hip on this plinth, so I'd probably just stay as I am. Okay, so if you do feel like you want to nod off and have a snooze, that's perfectly okay. I'm sure we can get the slides to you, or at least one or two of them if you need them. So I'm going to talk about BPE, or benign prostatic enlargement, which is essentially when the prostate grows and tends to obstruct the bladder. I'm not quite sure what the image is on the front. I found it and I thought it looked quite cool, but I don't have a story behind it, I'm afraid. I'd like to say it was a sort of skyline of Manchester somehow, but maybe if you look a bit harder, you might find a dolphin coming out of it. I'm not sure. So I've been given 45 minutes with instructions to talk for 25, and then we'll have a discussion for about 20. Okay, I might finish slightly earlier. I was just saying to Emma, the next speaker, that when I practiced this talk, I was finished in 8 minutes. So that's why I had to waste the first 3 minutes just ambling around without actually saying anything of use. So that's the method behind the madness, really. So I'm going to talk a bit about NICE guidance, because I think it's important to see how the people who are sending us guidance do things and what they tell us to do. I'm going to talk about this concept of MIST, minimally invasive surgical techniques, which essentially are UroLift, Resume, and the iTind. We'll talk about iTind in a minute, because I haven't yet figured out what the I is for. I'm assuming it's to get on the Apple bandwagon, but who knows? And then we're going to talk about the less misty things, a bit more clear things, the HOLEP, which is enucleation of the prostate using a laser, using green light laser therapy to effectively photoselectively vaporize the prostate. And then, of course, that thing we always hold up as the gold standard for treatment of prostate enlargement, which is the TURP. Anyone have any idea when the first TURP was done? Any guesses? It's not family fortunes. Don't worry, there's no wrong answers. Oh, it's like pointless, isn't it? 1870s. The Heidi High Brigade that's at the back there. No. Any other offers? Oh, you're very, very close. 1926. So it's nearly 100 years old, and we're still talking about it as the gold standard. I mean, that basically puts it up there with the wheel, doesn't it? There's nothing else. So we're going to talk a bit about that. Now, this is one of those slides that when I first started making this slide, I thought, this will look great. This is such a good idea for a slide. And then by the time I finished the slide, I thought to myself, don't worry, everyone's allowed one slide that they can apologise about. Okay, and this is basically mine. It looks a little bit more complicated than I hoped. What this shows is essentially the way published data has accrued since basically this century. So I've tried to ignore TURP, because as you can imagine, that would basically be 80 years here and then a couple tiny down here. And what you can see is that the dark blue probably doesn't come out very well, but the HOLEP is this sort of light blue here. And you can see that the body of evidence is just increasing all of the time. Okay? And at the top there, this is where the NICE interventions, or rather the NICE guidances were published. So you can see it doesn't take them long, does it? So if you think of the yellow one, which is iTind, which is the most recent, this is the new kid on the block. That was literally, the first publication came out in 2021. It didn't take them a year before NICE then issued some sort of guidance on that. Okay, so they're pretty much on the ball. These are the relevant NICE documents in relation to the techniques that we're going to talk about. And of course, they love their acronyms, don't they? But essentially, all of them, with the exception of the HOLEP one, which is Clinical Guideline 97, all of the rest were published very soon after these treatments had gained FDA approval and were into mainstream or publications. Okay, so, and the reason that they are published so early is that they are literally just interventional or technology guidance documents. And what they really say is, this is available, we think this is worth pursuing, and you can do it as an alternative to X, Y, and Z in a particular group of patients. And you can see that most of them here are really for glands between 30 and 80 cubic centimetres. So that is essentially the mainstay of NICE's sort of input into these BPH therapies. The real guideline was published in 2010 in May, and it was updated in June 2015. Now, June 2015, if you can imagine how life has changed in that sort of nearly 8 years. We've had 5 prime ministers, we've left the European Union, we've beaten a pandemic, and this one you'll really love. The national debt has increased by £800 billion. That equates to £35,000 per person in the UK. So we haven't been lazy, have we? We've been accruing all that debt. So it's a long time, isn't it, to still rely on that. And it was updated, and this is what they said. Now, the first statement here, you almost don't need to worry about. It basically just says offer surgery if the patient needs surgery. Great. The second thing is that it says offer HOLEP if you want as an alternative to TURP, TURVP. So, but they weren't changed. So that's 2010 information. So that's 13 years ago. So that's worse than having a child and then sending them off to secondary school without teaching them anything else in between. And unless you're homeschooling them, that probably doesn't happen, does it? Anybody homeschool their children? You did? Okay. It doesn't happen even if you're homeschooled, does it? Even then, they would learn more than this. So as we move on to minimally invasive techniques, the first is UroLift. So this has been out since 2013. That's when it got its FDA approval. Okay? And NICE offered its guidance in 2015. And I know probably some people, or many people, won't have seen the technique, but essentially all you have to think about is that when the prostate enlarges, it's almost as if somebody is closing the curtains on the outlet of the bladder. And so what this does is essentially put tiebacks in. So instead of closing the curtains, they're a bit like this. Okay, so it pushes the prostate to each side and obviously allows a flow. Okay. Now, there are 6, as of the end of 2022, there were 6 randomized controlled trials looking at UroLift. And the difficulty is, there's loads of evidence there. But actually, what a lot of these things do, the recurrent theme here is that the same cohort of patients are followed up multiple times. So, for example, the LIFT study, which is the key study for UroLift, it is the same cohort of patients at 3 and 5 years. Okay, so it's not separate data. And you'll see there, I've put on the top left of that slide, only 87 patients were looked at 5 years. Okay? And these are essentially the only 2 studies and the only group of patients that looked at UroLift against a sham. Others looked at this against resume treatment, which I'll talk about in a minute, or against TURP. All right, so it's not an enormous amount of data, even though it is a randomized controlled trial. So it's high-level evidence, but very low numbers. So what about the outcome? The key here really is to look at the IPSS, which is obviously the symptom score for the patient, and the flow rate. And what you can see then is that if you think about 3 years here, it pretty much halved the IPSS. And if you look at the flow rate, we're increasing the flow rate by around about 60%. Okay? And 80% of that benefit at 3 years is being maintained at 5 years. So it's a good outcome. Just to give you some idea of comparison, if you were to take medical therapy for this condition, you would probably be lucky to get that flow rate up to about 9, maybe 9.5. Okay, so it's significantly better than medication treatment. In the medical technology guidance that NICE delivered, it also looked, on this occasion, and again, this is one of the things you see about NICE guidance, is that it's not the same all the time. You'd like to think that everything had exactly the same cost-effective saving comparison, but of course it doesn't. And what they showed really was over 5 years, if you were to do a day case UroLift, and that definitely is the trend, then you're going to save considerable amount of money. Okay? Probably in the region of £200 to £250 per year. Okay? And remember that debt, £35,000 each. It's got to be worth it, hasn't it? Resume is slightly different. It achieves the same outcome in terms of flow rate and IPSS, but the way it does that is by injecting steam into the prostate and essentially destroying the prostatic tissue. So you do the injections, you leave a catheter in for anything between 3 and 7 days, depending on your preference. That's to accommodate the fact that after you've injected steam and you're about to destroy tissue, you get a bit of temporary swelling, which can tip people into retention. So you leave them with the catheter, take it out, and then hopefully things will improve. And this has been around really since about 2015 when it got its FDA license. Now, it looks here that we've got a huge amount of evidence, 11 trials. But in fact, 2 of those trials were in prostate cancer patients, so not the same thing. One of them was a cannibalization of different data to compare it with UroLift. And one of them was against a TURP. 7 of those studies, 7 of the 11, it was the same patient group. Okay, 2 of them looking at sexual function, the remaining 5 looking at the outcomes. And again, if you look at the IPSS and the Qmax, you can see we've more than halved the IPSS. The Qmax has increased by a significantly higher amount than you would expect from a UroLift. And it certainly looks that at least 80%, if not more, particularly if you look at the IPSS, of your effect at 3 years is being maintained at 5 years. So that's bringing in a degree of longevity that perhaps the UroLift device didn't actually have. Their cost comparison suggested, you see, this is at 4 years rather than 5 years, but essentially per year, you're probably saving about 125. So it's half as economical, perhaps, in terms of saving as UroLift. This is the iTind. This is the temporary implant of a nitinol device, which is what the TIND is. I don't know what the I is. As I said, it's probably an Apple rip-off. This is essentially, it's a bit like a metal cage, and it's got points at sort of 12, 7, and 5 o'clock. You put it in a local anaesthetic, you engage the cage, and it essentially causes pressure necrosis at those 3 points over 5 to 7 days. It gets taken out, and then hopefully you've got a channel opening, and you can pass urine very easily. That is very new. Okay, so FDA approved that in 2020. And the only real data that we've got is at 12 months. And you can see the improvement in the IPSS is around about 9, which is not dissimilar to the sort of improvement you get at 3 years for both Resume and UroLift. Okay, but of course, theirs is 3 years, this is 12 years. Now, the NICE guidance for this suggested that this was a good, innovative, and new type of technology, but it was unlikely to replace current treatments. All right? Now, that was 2021. I don't think in September 2021, we, the nation, the world, had any idea of what sort of backlog we were going to have to face after the pandemic. So I suspect NICE may have declared that slightly prematurely. I was about to ask any questions, but we're having a Q&A afterwards, aren't we? Right. So, they call them minimally invasive surgical techniques. I would say all of these things that we're talking about today are minimally invasive, but they've coined this term MIST, and so we're going to move on from the non-MIST things, which is, the first of these is HoLEP, and HoLEP is a laser device used to essentially enucleate the prostate adenoma, that bit of that's causing obstruction, and create that massive cavity at the end, so that we're really turning the clock back to when we were about 16. Okay. Does anyone remember when they were 16? No, I can't either. Better, yeah, fine. Let's not talk about age. It makes us all feel down, doesn't it? Okay, so we talked about the NICE guidance, clinical guidelines number 97, which was 2010, updated in 2015. The advice didn't change, and that was that HoLEP is a good alternative, and it should be in specialist centres. I think probably the thing I'd say is that this idea of a specialist centre, they used to be few and far between. I think now any unit that is going to develop HoLEP, that would be great. I don't think you necessarily need to think, oh, right, this is specialist and therefore it can only be done one place per region. If you've got the numbers, that's great. Since that documentation, there have been 19 meta-analyses. Okay, so there's a huge amount of data, and you saw that graph at the beginning, which showed that for HOLEP, the evidence was going up and up and up all of the time. What is becoming increasingly apparent is that larger glands do very well, and it appears that this technique, more than any of the others that we talk about, is independent of size when it comes to the outcome. This is the most recent meta-analysis, which was published in August of last year. 1,200 people involved, and as you can see, they're all pretty big glands. The results, less hemoglobin reduction, so in other words, they bleed less. Great, that's got to be worth having. Length of stay, much less. And again, when it comes, we'll talk about the backlog perhaps in a second, but when it comes to, in terms of length of stay, anything which reduces that or anything which becomes day case has got to be worth adopting. And you will see here that this is 3-year data, but look at how big that Qmax is. I mean, I don't think I've ever been able to pee that fast. Has anyone done their own flow rate? Can you remember how high it was? Do you mind me asking? 11. Okay. So still 4 more than mine. So we're in good company. Can you imagine can you imagine having a flow rate nearly 30? I mean, it's fire brigade worthy. And they've just had a 7.5% pay rise. I mean, you can't lose, can you? So massive increase in flow rate. And the IPSS is down here, it's 4.5. I mean, it's almost not worth talking about. I mean, I could make 4.5 just by being in a bad mood. So really, really good outcome data. Green light laser, the Boston XPS. This is essentially photoselective vaporization of the prostate, and you can see all of these look like, I've never done an operation that left such a nice cavity like that, but that's what the pictures suggest we're supposed to be doing. 6 trials in this group, although again, there's lots of multiple data, and in fact, the main trial that we talk about here, which is this Goliath trial, is essentially 3 of these references. So it's the same group of patients, really, that are followed up at multiple levels. And again, what you can see is the IPSS reduction is very good. Okay, remember, for minimally invasive techniques that we talked about, those first 3, the Resume, the Urolift, and the iTind, you're really looking at the most to get sort of a reduction of around about 10 points. So this is very, very good. And your Qmax increase, the flow rate increasing by 10, again, that's brilliant. Certainly better than any of the minimally invasive techniques. Not quite up there with HOLEP, though. I should say, I'm sorry, that the cost saving, if you do a green light laser, NICE did that, and they suggested you'd save about £60 per patient, provided 38% of them, I don't know why they said 38, but 38% were done in an outpatient setting. So if you can hit that magical figure, you might be making money. So here we have our almost 100 years old procedure of a TURP. Again, a lovely little cavity. If you haven't seen a TURP, the easiest way of thinking about it is it's like having a gun. And at the end of the gun is like a hot cheese wire. And you just continually bring the hot cheese wire through the tissue. It's quite fun. It's as close as a urologist gets to playing a video game, I think. It's not quite Call of Duty, but it's dare I say, it is quite fun. Is it the gold standard? Well, there have been lots of data around, of course, but because TURP is so old, nobody's really done any proper high-level studies on TURP. This is probably the most recent, well, not the most recent, but this is a published meta-analysis. And I just put this up because the figures here, you can see your IPSS is quite broad here, but it comes down quite well at 6 months. And the flow rate is much better. So the impact on your flow rate at 6 months is much greater than your impact on the IPSS. And that's because a large element of the IPSS could be irritative symptoms. And we know that if you do a TURP, for example, 2/3 of people will improve by 12 months in terms of their irritative symptoms, which means, of course, over 30% of people will still have that urgency. So it's probably just a short follow-up. There is a much better meta-analysis, which I've included here, and this was published last year in the BJU International, 27 trials, 3,000 men. And what was clear is that actually the data for TURP, although we call it the gold standard, it's not that great because it was already established. So it has become the de facto standard against which everything else is measured, without anyone having to stop and think, well, actually, is it the best thing? So the trial methodology is generally poor. It's clearly better than all of the minimally invasive techniques. It has a lower retreatment rate, which I'll talk about a bit later, but it does come with a higher complication rate. So the picture we're building really is that the minimally invasive surgical techniques probably aren't quite as good, but they're probably more acceptable in terms of their side effects than most things. So low volume but high level evidence for all. I think iTind is probably the exception to that. There isn't very much out there. That possibly will come. I think the jury is out. It would be easy for me to say that the guidelines, the NICE guidelines, were outdated. I don't think they're outdated as much as they just don't tell the full story because they haven't looked at all of the technologies. So it's in desperate need of a proper revamp or even a start from scratch. Okay, we can't rely, can we, on statements that are 13 years old. Minimally invasive techniques, yes, marginally inferior outcome. Certainly compared to HoLEP, it's significantly poorer. Their reoperation rate we'll talk about in just a second. But the big thing about them, of course, is that they're becoming increasingly outpatient. And if you can move things into outpatient settings, that's always going to be the winner. Okay? So before the pandemic, there were 25,000 TURPs or such like cases per year in this country. After the pandemic, the second biggest surgical backlog is in urology. Orthopedics are way up there, miles. Urology is next. And that requires to the tune of multiple billions of pounds to try and get back through. And one thing I think that's for sure is that if you look across the country, the access to theatre for urology as a whole has gone down significantly. Okay? Virtually everywhere you go, their access is lower. So anything that you can take from main theatres and put into an outpatient setting is going to win the day. Okay? And that, I think, is where the minimally invasive surgical techniques are going to triumph. Okay. This is a summary of the IPSS reduction, it's quite difficult following all those numbers. I find it very difficult following all those numbers. And so I thought I'll put them all on one slide so we can have a look. And I suppose it's pretty easy. If you look at the 5-year data here, you really are talking, HoLEP is streets ahead, isn't it, along with TURP compared to the other minimally invasive techniques. Okay, so yes, they're good, but they're not as good. What happens 5 years down the line? Well, look at the reoperation rates here. And again, I won't go through them all. You can all see that. But I suppose if you were to pick out a winner, you've got HoLEP here, very low reoperation rate, massive IPSS sustained reduction, and we've got that glorious 29 mils per second flow rate. Who wouldn't want that? Everybody wants that. That's the sort of stuff I dream about. So we talked about the pre-pandemic. So I think what's going to happen is that patients, they're less accepting of side effects. They're much more inquisitive now. In the old days, people would say, yeah, you're having a TURP. You might be incontinent, you might not be able to get an erection, sign there, off you go. Now that's not the case. So I think what's going to happen is people will probably compromise and say, yeah, I'll have a poor outcome. I don't mind if I have the procedure done twice. That's okay with me. And I think that's me. Thank you.
Thank you very much. So time for Q&As, and hopefully we've got as many questions as in the morning. So who's first?
Was there much in the data about the sexual function? Because patients I speak to, that seems to be a big motivational factor.
Yeah, it does, absolutely. I think the sexual dysfunction after TURP, I think, has always been overstated because what they didn't do for most of those studies was find out where their sexual function was beforehand. And of course, the biggest predictor of erectile dysfunction is age. And of course, so if you've got that elderly population having a TURP, of course, loads of them had ED afterwards. But there's no doubt that the minimally invasive surgical techniques, and HoLEP as well, the impact on sexual function is very, very much less. And I think it is fair to say that in the current era, men and women are much more active sexually to a later age than they ever were in the past, and that's just getting more and more. So I think it's a huge thing, yes. I think it's probably a deal breaker in a significant number of people. Yeah, great point.
Great talk, Ian. Just one question. Do you find the next sort of 10 years that for the mild to moderate enlarged prostates, that the myths are going to be the first line that's going to be offered to patients?
I think they will be, because then they won't take up theatre space. And I think most people, like we said before, they'd rather have something that is very, very low complication rate and have it done twice or 3 times. I think people are more accepting of that. Yeah. Probably what we'll find is that TURP gets done in specialist centres in the future.
Back to erections. Sorry, that's my job.
Back to my what?
Back to erections.
Oh, right,
that's my job, sorry.
I thought you said my erections.
No.
Because that's the second talk.
Okay. Which of those do you think has better outcomes with erections? Is there any evidence, or is that the future? Is that a future study?
Well, yes, it's future study, but there is data out there. The difficulty is most of them offer a range, and so things like Resume and HOLEP, that range is very close together. Right. So you're talking about 1, 2, 3% at the most, really.
Okay. And all your MISTs and your HOLEPs, all that can be done in outpatients? Yes, they can. Urolift certainly is very much down the track, because of course it was the first one in. So people are doing that local anaesthetic in outpatients. Yeah. Some people are doing Resume. It's not quite as widespread. HOLEP, I think HOLEP gets done as a day case. Okay.
I don't think anyone's doing it as an outpatient, actually.
Okay, thank you.
In clinic. Oh, and ITIND, of course, is outpatient-based, yeah.
Hi, Ian. Great talk. Be careful.
I know.
Majority of patients.
This is just to show that I'm on the edge.
Yeah, be careful. The majority of audience are ladies when you talk about erectile function. And I just wanted to ask you about ITIN, which is the new kid in the block. Do you have any experience first?
No, only their simulation.
Simulation.
Yeah.
And I listened to Neil Barber. He has done some them in a research basis or whatever he has done, and it looks like for me this technique is mostly for the bladder neck stenosis rather than prostate enlargement, because it actually expands the bladder neck level and up to 2 centimeters from the bladder neck. What are your thoughts?
Yeah, I think it might well find its niche there. I think it's just so early days with it, and I gather even from the sort of company simulation, I think they get a lot of irritation, and that irritation can go on for quite a number of weeks. But yes, it might well find its niche sitting exactly there. I think it's incredibly early, actually. I'm surprised that NICE saw fit to comment as it did with literally, 1 or 2 studies. It was quite early, probably.
Hello. Thank you so much for your talk.
Pleasure.
I've not looked after a man in like 8 years. I wouldn't know what to do with one.
They're definitely worth looking after, men, I think. I mean, that's just my own personal view, but I
was wondering, with your knowledge and your lovely presentation, what would you choose?
Oh, good question.
You have to sign this in, you have to put this in writing and then produce it if you ever...
Yeah, I think what I'd say is I might choose something different depending on how well, now compared to when if I ever make it to 70. I think now I would probably have Resume, actually. And I think I'd have it because I'd accept a poorer outcome for an almost non-existent side effect profile, I think. And it's quick, it would be convenient for me to be in and out, Yeah, but I think if I had a huge prostate gland, I would have HOLEP. I think that is the most effective and the best treatment. It just doesn't fit in with lifestyle all the time, I think.
How do you think these new technologies would expand the population that are eligible? Because I think GPs still kind of think, oh, they're probably not fit for a TURP. But, should we now be referring people who are a lot more frail because they could have these procedures?
That's a great question, and I think yes, they should. So 2 aspects of that. One, you don't have to be as fit to have a minimally invasive technique as you do to have a TURP or a HOLEP, for example. So yes, I think increasingly, that sort of cohort who have long-term urethral catheters, or suprapubics, yes, absolutely. I think
they will come forward. And I think the other group is that cohort of patients who are on medical therapy, but they're not really that happy, but they don't want to commit to having a TURP or something like that. So I think our threshold will go north to get the unfit patients, and I think our threshold will come down for those people who are not satisfied with medical therapy. So I think you're right, it will expand at both ends. Yeah, great point. I could lean over. I've got one of these mobile mics.
Thank you for that talk. It's really helpful. As a pelvic floor physio, not so NHS practice, but more so my private practice, more and more men are coming in gutted with urinary incontinence post. And I guess that wasn't really spoken on your outcomes either. So with your experience, how well are these like prepped or educated or consented, or is that an outcome measure looked at in urology? Or
yes, it is, and in my view, it should be on every consent form. I suspect it probably is. It's certainly on the Bowes procedure-specific consent forms. I think if you're going to do any of these things without telling them there's a risk of incontinence, I think you're in trouble.
I think they must know, and it's good to hear that, because I think maybe at the time they just think, oh no, that won't happen. And I think men seem to be more bothered and more aware. They don't get discharged blood, urine, so a little drop is massive for their quality of life.
Well, we're sensitive. Is that what you mean?
Yeah.
I think you're right. Yeah, we're quite, as much as we're worth looking after, I think we are quite precious. Yeah.
But it's interesting, because when you kind of get to the nits and grits and you're really looking at how much they're leaking, sometimes it is so small, but they really, really struggle, don't they? And do you find with your practice and where you work, do you have a good, do they see a pre-op or post-op physio where you work, or what kind of support is there?
No, they don't actually, no. And No, they don't. And I suspect the reason for that is that the rate of incontinence in terms of percentages is very low. So we probably wouldn't cope with getting everybody to see a physiotherapist beforehand when, at least 95% of them won't have any issues afterwards.
Yeah.
So no, they don't. Yeah, for radical prostatectomy, yes, they should, because of course.
And do they see physio where you work?
I don't think they do actually. No. No, because if you think about radical prostate, they ought to be seeing physiotherapy, and they ought to see an andrologist because they're erections as well.
Yeah.
But of course, hardly any of them do.
I know. That's what I'm seeing more come through privately, just kind of left and struggling with erectile function and incontinence. Do you see the same?
Definitely.
Something to be worked on, I think. Yeah.
Yeah, definitely, absolutely.
Any other questions? That's good. It leaves more time for buying raffle tickets, of course. I have one question actually. We talked about loss of sexual function and other side effects. How much of that, particularly with the more invasive older treatments, is dependent on the skill of the surgeon? Do you find there's any correlation between very junior people and...
Being recorded, yes. So my own rate is 0%, but yes, you're quite right. I think we would all accept that outcomes are related to volume. So the more you do of something, the better you're going to become and the fewer side effects you're going to have. The TURP, though, I don't think it's in its heyday anymore. I think it's coming down, but in its heyday, it was done by pretty much everybody at a very high volume. So I think the thing that made the most difference is how aggressive people are with the TURP. So if you consider you've got a hole like this and you want to make it this big, so the more aggressive your TURP, almost certainly the more complications you're going to get. And the longer your operation, the more complications you're going to get. So I think those people who were going right to the wire, yes, of course, they probably would have more. But I would stress that lots of the data for TURP is contaminated because we didn't know what the patients were like beforehand. Okay, so it is quite a difficult group because we've just assumed it's okay. But yes, it's of course it's surgeon related.
And are the more modern techniques more repeatable? So I presume with the older technique, it depends what you do. With some of the new ones, they look as if you sort of do it one way and that's the only way.
Well, Yes, I think that is true. The amount of skill you need to do the minimally invasive techniques, I think, is probably going down. I mean, if you think of Resume, the machine actually tells you pretty much exactly what to do. It tells you when to pull the trigger. It tells you when to release the trigger. You know, it's almost foolproof. So, yes, I think the learning curve is much shorter for the minimally invasive techniques. HOLEP is different. I mean, the learning curve for HOLEP is said to be between 20 and 30 cases. And so that could take quite a long time, couldn't it? Whereas the minimally invasive one's very, very straightforward, yeah.
Thank you very much.
My pleasure. Thank you. Thank you.